Hello, my name is Jennifer Wright. I'm a student at Roberts Wesleyan University in the Master's in Nursing Leadership and Administration program. This is my presentation on the Covenant of Care Transition Bundle to prevent wound recurrence by providing holistic care grounded in the fundamentals of care framework. I am currently a nurse manager at the wound clinic and I've worked there for 10 years. Chronic wounds such as venous leg ulcers and foot ulcers pose a significant and growing burden due to high recurrence rates and their impact on patients' daily lives. Beyond delayed healing, these conditions affect mobility, independence, body image, emotional well being, often leading to social isolation and reduced quality of life. Managing chronic wounds extends beyond physical treatment, as patients must constantly adapt daily activities like walking, bathing, and footwear selection to prevent recurrence. This ongoing vigilance can create emotional, physical, and financial strain, highlighting the need for care that addresses the whole person rather than just the wound alone. Effective prevention requires an integrated, person centered approach that supports physical, psychosocial, and functional needs while promoting self management. Central to this is a strong nurse patient relationship, which fosters trust, communication, and patient engagement, ultimately improving adherence and reducing the risk of wound recurrence. GS is a 55-year-old male with morbid obesity who successfully treated for a venous leg ulcer and discharged from the wound clinic February 15, 2024. His care primarily followed a task-oriented biomedical model with clinic visits focused on wound measurement, documentation, and compression therapy. Due to time constraints and high patient volume, there was limited opportunity for patient education or relationship building. Although the wound healed, GS was given only brief discharge instructions to use compression, stockings, and moisturize his legs daily, without a thorough discussion of his ability to manage these tasks or access necessary resources. Important aspects of GS's care were overlooked, including assessment of his physical ability to apply compression stockings, financial limitations, and readiness to learn. The lack of individualized education and collaborative communication left him feeling unprepared and unsupported. Without guidance or confirmation that he could realistically follow the care plan, GS struggled with adherence after discharge. The absence of a therapeutic relationship further prevented him from voicing his concerns or seeking clarification about his care. As a result, GS experienced recurrent leg swelling and was unable to consistently use compression therapy, leading to the development of new full thickness wounds. This recurrence required additional treatment and extended healing time, negatively impacting his quality of life and increasing healthcare costs. His experience highlights a common gap in outpatient wound care, where healing is achieved but long-term self-management is not sustained. Implementing an evidence-based covenant of care transition bundle could better address patients' physical, psychosocial, and relational needs, improving outcomes and preventing wound recurrence. A wound clinic located in Rochester, New York, serves patients from a large surrounding rural area with a mission to deliver high quality, compassionate, and innovative care. The clinic typically sees 35 to 50 patients per day, most whom are referred by their primary care providers or specialists such as vascular surgery and podiatry. Care is largely focused on managing venous leg ulcers and foot ulcers associated with chronic conditions that require ongoing treatment and monitoring. The clinic is staffed by 4.5 nurses and 4 advanced practice providers, with each nurse responsible for approximately 8 patients per clinic day. Limited financial resources prevent additional staffing, resulting in time-constrained, task-oriented visits. This environment prioritizes wound care tasks like bandaging and documentation over patient education and relationship building, leaving psychosocial needs insufficiently addressed. Leg and foot wounds frequently recur after discharge due to limited ongoing support, lack of individualized discharge planning, and patients' insufficient understanding of long-term prevention strategies. In many wound clinics, high patient volume and limited nursing resources contribute to a task-driven model of care focused on wound assessment, documentation, and dressing changes. This approach leaves little time for meaningful nurse-patient interaction, limited opportunities to build therapeutic relationships, and provide effective education for self-management. As a result, discharge instructions are often generalized with minimal discussion about whether recommended strategies such as compression therapy, skin care, edema management, and offloading are realistic within the patient's daily life. Like the case of GS illustrates how these gaps can lead to poor outcomes. His care focused on necessary clinical tasks, but did not address his individual circumstances, including physical limitations, financial constraints, or ability to apply the compression stockings. Without a trusting relationship or collaborative care planning, he was discharged with standardized instructions and no follow-up support, leaving him unprepared to manage his condition. Consequently, he did not adhere to compression therapy, leading to recurrent edema and the development of a new wound. This pattern reflects a broader issue in wound care. When care prioritizes tasks over holistic, patient-centered approaches, wounds may heal temporarily, but the underlying factors driving recurrence remain unaddressed. Patients with venous leg ulcers and foot ulcers are typically middle-aged to older adults, often with multiple comorbidities such as diabetes and hypertension that increase their risk of complications. Many individuals face socioeconomic challenges, including lower income, limited education, and reliance on public insurance or lack of adequate coverage. These factors can restrict access to preventative resources such as compression therapy, specialized footwear, medications, and transportation. Racial and ethnic disparities further contribute to poorer outcomes, with minority populations experiencing higher rates of complications such as amputation. These populations are particularly vulnerable to unmet physical, psychosocial, and relational needs. Physical limitations related to age and chronic illness can hinder mobility and the ability to perform self-care tasks. Limited health literacy and lower educational attainment make it difficult for patients to understand and apply generalized instructions, especially when education is not individualized. At the same time, social isolation, lack of caregiver support, and competing life stressors contribute to anxiety, depression, and reduced engagement and self-management. In task-driven clinic environments, these complex needs are often overlooked, leaving patients without support necessary to manage their condition effectively. As a result, patients face significant challenges in preventing wound recurrence and maintaining overall health. This highlights the need for a more holistic, nurse-led approach that addresses not only clinical care, but the broader social determinants of health. Interventions such as a Covenant of Care transition bundle can provide individualized education, structured self-management support, and stronger nurse-patient relationships by focusing on physical, psychosocial, and relational needs. This approach promotes health equity, improves patient outcomes, and reduces disparities in wound care. Among adult patients attending a wound center for leg and foot ulcers, how does the implementation of a Fundamentals of Care transition bundle, including individualized education initiated at admission, family integrated planning, and structured nurse-led follow-up, compare to generic discharge instructions in reducing ulcer recurrence rates and hospital readmission while improving self-efficacy and adherence over a 12-month period of time? The objective of this proposal change is to enhance holistic well-being, comfort, and dignity of adult patients with leg and foot ulcers through the implementation of a covenant of care transition bundle by restoring a trusting therapeutic relationship and providing individualized, compassionate support. This project aims to empower patients with the self-efficacy needed to confidently manage their care at home, thereby preventing the physical and emotional distress of wound recurrence and hospital readmissions over a 12-month post-discharge period. The literature search, including CINAHL, the Cochrane Library, and PubMed, due to their strong coverage of nursing and medical research relevant to evidence-based practice. Keywords such as self-management, patient education, wound recurrence, foot ulcer, venous leg ulcer, and prevention were combined using Boolean operators and, or. Inclusion criteria focused on studies from the past 30 years addressing wound recurrence and self-management or education strategies, while unrelated wound types in older studies were excluded. Articles were screened by title and abstract, followed by full text review with one reviewer determining eligibility based on the criteria. A total of 16 articles were selected, highlighting prevention of ulcer recurrence, self-management of chronic disease, individualized education, and nurse-patient collaboration. Evidence showed that venous ulcer recurrence is often linked to minor trauma and barriers to compression stocking use, such as discomfort, difficulty applying compression, and the cost. Studies also found that proper offloading and gradual reloading reduce foot ulcer recurrence, while structured self-management programs improve patient outcomes. Additionally, face-to-face education with follow-up support enhances adherence to self-care practices. These findings were organized into two themes: patient experiences with self-management and education, and evidence-based strategies to prevent ulcer recurrence. As seen in the graph, the theme of patient experiences related to clinical issues of concern is supported by evidence from Level 1, Level 2, Level 4, and Level 6 studies. Additionally, the theme of evidence-based strategies supporting the proposed change is supported by evidence from Level 1, Level 2, Level 3, and Level 6 studies. Various levels of evidence support the effectiveness of self-management education programs in improving outcomes for patients with chronic conditions. This evidence is strong enough to support a proposal because it includes multiple levels of research, with high-quality Level 1 and Level 2 studies providing reliable support and additional Levels 3, 4, and 6 offering practical insight and consistency. Both themes are backed by overlapping high-level evidence, showing the findings are consistent across different study types rather than isolated results. Lower-level studies also contribute valuable information about patient experiences and real-world barriers. Together, this combination creates a well-rounded, credible foundation, demonstrating that self-management education programs are effective and applicable in clinical practice. The nurse-led self-management program will be guided by two theoretical frameworks: the self-determination theory and the fundamental of care framework. Within a nurse-led self-management education program, the self-determination theory supports the idea that participants are more likely to engage in self-care practices when they feel autonomous, supported, and confident in their ability to manage their condition. The Fundamentals of Care framework, developed by Allison L. Kitson and colleagues, emphasizes that high-quality nursing care requires integrating the nurse-patient relationship with a patient's physical, psychosocial, and contextual needs to provide holistic, person-centered care. By prioritizing trust, communication, and coordinated support, the framework ensures that the fundamental care needs are consistently addressed, leading to improved patient outcomes, safety, and overall satisfaction. When combined with a self-determination theory, nurses can address both educational needs and the relational aspects of care that influence patient engagement and adherence to treatment plans. Together, these frameworks support the development of a structured, nurse-led self-management program that promotes patient participation, strengthens the nurse-patient relationships, and improves long-term self-care outcomes. The Fundamentals of Care framework emphasizes the importance of therapeutic nurse-patient relationship that addresses the patient's physical, psychosocial, and contextual needs. In wound care, focusing only on treating the wound is insufficient. Preventing recurrence requires attention to factors that influence a patient's ability to perform self-care after healing. The Fundamentals of Care highlights trust, communication, and mutual respect, creating an environment where patients can share concerns and nurses can identify barriers to adherence. Self-determination theory complements this approach by providing a motivational framework to support sustainable self-management behaviors. While the Fundamentals of Care ensures care remains holistic and patient-centered, self-determination theory offers a structured roadmap for implementing nurse-led education programs that encourage active patient engagement. Together, these frameworks reduce the risk of purely task-oriented care and strengthen the theoretical foundation for a holistic nurse-led self-management program. By integrating relational, motivational, and practical elements, nurses can address both the clinical and personal aspects of care. Ultimately, this combined approach empowers patients to take an active role in their care, improve adherence to preventative strategies, and reduce the recurrence of venous leg and foot ulcers, while promoting dignity, independence, and long-term health outcomes. The self-determination theory guides patient-centered care by supporting autonomy, competence, and relatedness. Autonomy support encourages collaborative goal setting, tailoring education to patient preferences, and involving patients in decisions about compression therapy and self-care. Competence support focuses on providing education about disease process, hands-on training for compression and daily foot care, breaking complex behaviors into manageable steps, and addressing barriers to adherence. Relatedness support engages the patient support system from their first visit, providers, ongoing nurse follow-ups, and connects patients with support groups or community resources to foster emotional and social engagement. The Fundamentals of Care framework complements this approach by emphasizing holistic, patient-centered relationship care. The core layer focuses on establishing a trusting nurse-patient relationship, identifying barriers, providing individualized education, and using self-monitoring diaries and goal setting to promote healing and prevent recurrence. The middle layer integrates care, aligning wound treatment plans with patients' psychosocial and physical needs through nurse-led huddles and collaborative problem solving. The outer layer addresses the broader context of care, including follow-up visits, phone check-ins, community referrals, tracking progress in self-management wound registry, and sharing detailed self-management plans with a primary care provider to ensure continuity of sustained adherence. The clinical change trajectory begins at the patient's first wound clinic visit, where the provider and nurse introduce an optional self-management program and obtain consent and participation in the registry to track outcomes and barriers. The nurse establishes a collaborative, trusting relationship with the patient and provides a diary for tracking adherence and symptoms at home. Individualized education starts immediately, with the provider determining the clinical pathway, such as progressive reloading for foot ulcers or compression therapy for venous leg ulcers, while the nurse delivers targeted teaching on disease processes and prevention. Understanding is reinforced through teach-back methods to ensure the patient can safely manage their care. After healing, the patient attends biweekly follow-ups for up to 3 months, during which the nurse evaluates tissue status, reviews the diary entries, and facilitates brief reflective discussions to address barriers and strengthen self-management skills, while the provider monitors readiness for increased activity and potential complications. From 3 to 12 months post-healing, care transitions to monthly in-person visits with bi-weekly phone check-ins to support adherence, monitor progress, and provide ongoing encouragement. The nurse and provider collaborate to adjust the care plan as needed, with patients who struggle returning to more frequent follow-up. At 1 year without recurrence, the patient is discharged back to their primary care through a structured process that includes a comprehensive summary of progress, education, and long-term prevention strategies shared with relevant providers. By program completion, the patient is equipped with knowledge, skills, and support necessary to sustain self-management and prevent wound recurrence. Ms. Brinley Alden, a 68-year-old patient, presents to the wound clinic with a venous leg ulcer following months of lower extremity edema and limited mobility. Upon enrollment in a wound recurrence prevention program, she receives structured, individualized education during each visit, focusing on foundational knowledge such as the cause of venous leg ulcers, the importance of compression therapy, and lifestyle strategies like mobility and leg elevation. The nurse establishes a therapeutic trusting relationship, introduces self-management tools including a care diary and registry, as well as using teach-back method to reinforce understanding. Over several weeks, her wound progresses towards healing with consistent care and education. After healing, Ms. Alden enters the follow-up phase centered on skill development and adherence. The nurse reinforces her individualized care plan, assists with obtaining and applying compression stockings, and addresses barriers such as difficulty with application by introducing adaptive devices. Through biweekly visits, the nurse reviews her self-management diary, collaborates on problem-solving strategies, and provides ongoing education to strengthen prevention behaviors. This phase emphasizes building confidence, improving consistency, and integrated care into her daily routine. Following 3 months of sustained healing, Ms. Alden transitions to a maintenance phase with less frequent visits and regular follow-up phone calls. Education focuses on reinforcing long-term self-management, including compression use, skin care, and early recognition of complications. By 1 year post-healing, she demonstrates independence and confidence in managing her condition without recurrence. A structured discharge ensures continuity of care with her primary care provider, highlighting how consistent education, supportive tools, and a strong nurse-patient relationship can promote lasting wound prevention. The nurse-led self-management education program in the wound clinic incorporates key ethical principles to ensure safe, patient-centered care. Guided in the Fundamentals of Care framework, it emphasizes a trusting nurse-patient relationship in holistic care. Patient autonomy is supported through informed consent, ensuring individuals understand the program's goals, expectations, risks, and alternatives before voluntarily participating. This fosters informed collaborative decision-making. The principle of beneficence is reflected in the program's goal of improving outcomes, preventing wound recurrence, and promoting self-care through evidence-based education. Non-maleficence is upheld by ensuring patients can safely perform interventions such as compression therapy with alternatives provided when risks or barriers exist. Together, these principles support patient safety while encouraging active participation in care. Justice is addressed by providing equitable access to the program regardless of socioeconomic status or health conditions, while also maintaining patient confidentiality through secure data practices. Training ensures nurses are proficient in both education and documentation, with attention to maintaining meaningful patient interactions despite the use of electronic systems. The program also helps reduce nurse moral distress by prioritizing time for education and relationship building. Potential challenges such as depersonalization during documentation and limited patient understanding are addressed through strategies like completing documentation after visits and using the teach back strategy method. Overall, the program promotes ethical, safe, and equitable care. A stakeholder meeting was held on April 2nd in the Wound Clinic conference room, and including the medical director, program administrator, 2 advanced practice providers, and 3 staff nurses. The discussion focused on the common issue within the clinic: frequent recurrence of wounds after initial healing. A proposed nurse-led self-management program was introduced, emphasizing the importance of strengthening the nurse-patient relationships and moving beyond task-oriented care. The program would include structured follow-up visits, ongoing patient education, and a self-management registry to track adherence, barriers, and outcomes while improving communication across providers. Nurses and advanced practice providers responded positively, acknowledging that the current workflow limits their ability to provide education and build meaningful relationships with patients. They recognize the potential for the program to improve adherence and long-term patient outcomes. In contrast, the program administrator and the medical director expressed concern about the financial feasibility, particularly around billing and reimbursement. While they were open to the idea, they emphasized that provider involvement and sustainable billing structure would be necessary for implementation. The project's strengths lie in clinical support from the nurses and the providers who are directly involved in patient care, as their engagement is essential for success. However, challenges include securing administrative and financial backing, especially given the shift from revenue-generating wound treatment to preventative-focused care. Moving forward, determining viable billing options is critical. If this is not feasible, an alternative approach would be to integrate more individualized patient education and self-management support into existing clinic visits rather than implementing a long-term follow-up program for these patients. The total cost associated with training and supplies for the Self-Management Covenant of Care Transition Bundle is approximately $7,900. Training expenses include time for nurse educator to deliver 4 one-hour educational sessions on the wound registry and patient education template, totaling $260. Staff participation in these sessions represent an additional cost, with nurses accounting for $1,300 and advanced practice providers contributing $312. Supply costs, support, engagement, and education include $3,000 for patient diaries and $2,400 for instructional handouts. Additionally, $660 is allocated to provide meals for 11 staff members across 4 training sessions. Overall, these combined training and supply costs represent a modest investment to support effective program implementation and staff preparedness. Preventing a single wound recurrence costing over $16,000 allows the program to reach its break-even point, with preventing one also recurrence within a year. With a daily volume of 35 to 50 patients and an average healing time of 3 months, the program is well positioned to achieve a positive return on income through consistent enrollment and effective recurrence prevention. Additional benefits include reduced hospitalizations and procedures, improved patient quality of life, and alignment with value-based care initiatives. By emphasizing patient education and self-management, The program enhances nurse-patient relationships and supports better long-term outcomes. Overall, this relatively low-cost intervention has strong potential to reduce healthcare costs while improving patient-centered care and clinical outcomes. The approval process begins with an initial meeting with the Associate Director to present the proposal, clarify the required approval steps, and identify key stakeholders. Following this, the project is presented at the unit level to the Medical Director, Nurse Manager, and Program Administrator, whose approvals are necessary due to the project's impact on clinical workflows, staffing, and budget. Once unit level approval is obtained, the proposal is submitted to the Nursing Research and Evidence-Based Practice Council for review of the supporting evidence and alignment with the organizational goals. After the council approval, additional meetings are held with senior leadership, including the ambulatory nurse educator, ISD builder, and ambulatory nursing director, to address operational planning, workflow integration, and electronic health record support. Final approval is granted by the ambulatory director of nursing based on recommendations from leadership and council reviews, as well as evaluations of resource and budget requirements. To accurately measure outcomes within the Covenant of Care transition bundle, integration of the self-management wound registry into the electronic health record is essential. The registry allows nursing staff to document wound healing dates, track recurrence, and measure how long patients remain wound-free. Monthly and annual audits provide data on reductions in recurrence rates. The registry further enables individualized care planning by allowing nurses to select and track interventions based on wound type. For example, in venous leg ulcers, interventions include adherence to compression therapy, leg elevation, skin care, and progress tracking with adherence documented as a percentage. Similarly, for foot ulcer preventions, nurses monitor factors such as foot inspections, dermal temperature, offloading, blood glucose control. Nurses also record successes and barriers, using this data to guide collaborative problem solving with patients. Hospital readmission rates are evaluated through retrospective electronic health record reports to assess whether patients return with wound-related complications within 12 months. Finally, the registry incorporates patient-reported outcomes through a self-management rating scale from 1 to 10, capturing the patient's confidence and engagement in managing their condition over time. An additional Likert scale question evaluates the strength of the nurse-patient relationship by asking how well patients feel their nurse understands their personal barriers to care. Together, these measures provide a comprehensive evaluation of clinical outcomes, patient experience, and the effectiveness of the program in promoting long-term self-management. Developing this evidence-based practice proposal significantly shaped my growth as an advanced practice nursing student. Initially, selecting a topic, particularly one addressing missed or invisible nursing care, was challenging, but it became engaging once I explored the nurse's role in preventing wound recurrence through therapeutic relationships grounded in the fundamentals of care framework. While evidence on physical prevention was abundant, research on missed nursing care was more limited, likely because this invisible care is less frequently measured despite its importance in holistic patient support. My focus evolved from a narrow biomedical approach to a broader perspective that considered how clinical workflows and task-oriented environments impact patients' fundamental of care needs. This project also deepened my understanding on the complexity involved in implementing practice change. I learned that strong proposals require multiple sources of evidence, theoretical grounding, and consideration of workflow and financial implications. It highlighted how unit culture and staffing influence nurses' ability to build therapeutic relationships, which are essential in delivering comprehensive care. Through this process, I strengthened my skills in evaluating and synthesizing research, improved my professional writing, and gained confidence in advocating for change. Moving forward, I will approach clinical problems with a clearer problem identification process and openness to evidence-based solutions. Recognizing the responsibility of master's prepared nurses to drive meaningful improvements in patient care. Ultimately, this experience has reinforced that meaningful practice change in nursing extends beyond addressing physical outcomes to recognizing and prioritizing invisible aspects of care, requiring a commitment to therapeutic relationships, critical appraisal of evidence, and sustained openness to growth in order to deliver truly holistic, patient-centered care.